Okay, everybody, let's take a quick look at a mental status exam. As I mentioned in class, psychologists, when they think of a mental status exam or when they do a mental status exam, it's much more formalized and it is really kind of an exam. They're asking their patients to, do calculations, count forward and backwards using kind of a certain amount of numbers, either serial sevens, which is, you're going to count back from 100 in using sevens, or they want you to memorize 3 words and then recall those 3 words later on. Let's see, they also do kind of little exam whether or not they can show insight into particular phrases that have meaning, to see if they can kind of understand what those phrases are trying to get at. So for psychologists, the mental status exam really is kind of something that is much more formal and really is getting at mental processes and insight using particular questions. A mental status exam for us as social workers, clinicians, typically a mental status exam is more so observations. What we're observing is their affect, so their facial expressions and emotions. We're looking at their body movements. We're looking at the way that they interact with us, the way they show judgment during the session. Are they showing insight into what we're talking about? Do they understand? So those are some of the areas. Let me cover those briefly here. You can find a lot of these mental status exams online just to become familiar, but I did want to cover this just so you can see. So one of the very first categories is general appearance. So you're looking, your hope is that they have kind of normal appearance, that they're groomed, that they're well groomed, good hygiene, maybe they're casually dressed. But for the most part, that would be kind of your hope in your typical client. Well-groomed, good hygiene, and really nothing out of the norm. However, certain populations, I've worked with the homeless population for years in Ogden, and certainly in dealing with particular clients, they do have some changes in their general appearance. Maybe they're more so disheveled, so their clothes are kind of really in tatters, their hair and face, you can just tell they just not even threw themselves together. They just kind of showed up, didn't put themselves together. There may be body odor involved and poorly groomed. So those are some of the responses depending on the population that you'd be working with or the clientele. But I've also had clients that because of severe depression, they've kind of fallen into those states as well where they're not well groomed. They kind of come to the session very not put together. So that's why we have that area. Interpersonal relations. So you're paying attention to behaviors. How are they in the session? Are they crying? Or do you find that, what are some other ones? Maybe they're fidgety. Maybe they just can't quite sit still due to some sort of maybe attention deficit or anxiety, or even they're in a manic phase, or due to substances or substance use. Maybe they can't sit still very often or much in your office, so they're kind of moving around quite a bit. I would say for the most part, again, what you're hoping to see usually is either calm, good eye contact, cooperative. Those are the ones that you would hope to see and that you're kind of wanting to see. But the rest of these, I would kind of look over and see. These are words that you'll just kind of want to have in your mind to be able to use when you're done with the session. You can, when you're going through the mental status exam, after the conversation with the patient, you can go through and say, you know what, they really had intermittent eye contact or poor eye contact. They were uneasy to be there. Maybe they were even pacing or had to get up and stand up because they were so anxious. So just getting used to using some different descriptors would be great for you to know for a mental status exam. Motor activity, this is similar to some of those above that I mentioned. Let's see. What we hope, again, the big hope is that it's normal physical activity. They come in your office, they're fairly comfortable. Maybe there might be some nervousness, but for the most part, they're sitting down, they're relatively calm. That's what we're wanting. However, all of these other categories, such as motor tics, abnormal movements, akathisia, which is where they're kind of this restlessness, they can't quite sit down, but it's almost a nervous restlessness and not so much like fidgety, which is more kind of attention deficit, or if they've used substances for quite some time. So those are some of the psychomotor activities that you'll want to pay attention to. And again, if you can kind of look at the screen, some of those words, if you don't recognize, I would kind of Google them, type them in, kind of get an idea of what they might mean. But for the most part, that's what you're looking for in the psychomotor activity. Muscle tone and gait. So how did they come into the office? Did they walk in normally? Were they hunched over? Was it very difficult to walk? These are things that you're, again, all of this is really for us as social workers. We're just observing. So just paying close attention to how they're acting and interacting with you. And then finally, at least for this section, speech and language, what we're hoping for is pretty much normal. That's our hope, and appropriate. So normal and appropriate speech and language, maybe it's clear. However, there are plenty of patients of mine and clients of mine where maybe they are loud, okay? Maybe their speech is slow. Another one is that I often mark that you'll see quite frequently with those who are dealing with bipolar disorder in any sort of manic phase, pressured speech, meaning they just can't even get it out fast enough. Their mind is racing so quickly that their speech is, they're stumbling over themselves quite a bit, and you can't even get a word in edgewise because it is so pressured to come out. So those are some areas of speech and language that you'll want to pay attention to. All of these things, you don't necessarily need to have a sheet with you as they are talking. However, I would take some notes. If you were noticing during the session they're speaking very loud and kind of yelling. I've had some folks in the next office come after the session and be like, Nate, were you okay in there? So some patients are very loud, others might be very soft, and you can barely hear them. So these are things that you may just want to jot down in your notes as you are listening to them during the session, so that you can remember during the status exam portion of your notes, you can quickly mark that down or recall what you observed. Okay, this is part of the mental status exam. These are some of the very most common ones that will help really substantiate your diagnoses. So these areas here, mood, affect, thought process, thought content, those are really the areas that will help kind of generate part of your diagnoses, or at least kind of substantiate and correlate between the diagnosis that you put down and what you observe during the session. Hopefully they're matching up. So for example, during mood, if they are showing signs of depression, they're crying, they're kind of low intensity face that's kind of drooping, or they're showing signs or talking about depression, you will definitely want to mark down that you've observed depression during the session. If they are in more of a kind of hypomanic or manic state or other agitated state, you might be marking such things as irritable or angry. They might have elevated or overly happy mood. There's been other forms that I've used. In fact, I think the one on my medical record system has pleasant as a mood, which many of my clients, they are pleasant. However, they often show signs of depression as well. So sometimes there's a word that isn't on this particular form, but the word is congruent. So if you put mood congruent, that would mean or indicate that their mood kind of changed at various times during the session, but I would put appropriate and congruent. That would let kind of if anybody was to read the note, let them know that during the session it tracked well with their mood. When they were sad, they showed kind of the facial expressions, and during that portion of describing their depression, their mood was congruent with that. However, if the mood shifted during the session and you were talking about something that was more pleasant, maybe their mood shifted and they were happier. So mood congruent would indicate that the conversation during the session was appropriate and followed kind of the subjects that you were talking about. Affect goes very closely with mood because it should match up. So if a person is describing depression, typically their affect would be something like sad or down or low intensity. You would hope that their affect would be appropriate, meaning, and that's a word similar to congruent, meaning their affect followed what the mood was doing. There we go. So appropriate affect and congruent affect, those two are the ones that you really kind of want. Or even full affect, meaning that they showed the variety of emotions. Such things as constricted, meaning that their face was just kind of tight, not necessarily in anger, but they really didn't show any expressions. Flat is kind of their face is just, there's nothing going on there. No matter how happy, sad, angry the conversation should be kind of reflecting on their face, they are just like sheet of paper. And those other words as well, labile, just again kind of really low intensity, not much movement going on. All right, let's move on to thought process. This is one typically that, again, you're hoping that it's logical and organized so that they're able to track you. They're showing that their thought process, for the most part, they can make connections. They're kind of keeping things in order as you speak. However, let me tell you, I've got plenty of clients that typically those who are in kind of the bipolar range or attention deficit range or even anxiety disorders, I will tell you their thought process can be very disorganized, or preoccupations. They're kind of really worried throughout the session about what's going on. I will have clients kind of stop kind of mid-thought and either apologize about things or show their worry about other things, so their thought process is preoccupied. Let's see if there's any other ones that I'd want to mention. For bipolar, typically racing thoughts and tangential thoughts is very common with bipolar and attention deficit disorders. Their thoughts are bouncing all over, the subject matter's bouncing all over. So racing thoughts, they just are going so fast you can barely keep up. And the tangents that they go on, they're matching different subjects together that really have no relevance, but they're jumping from subject to subject. Let's move to thought content. Again, your hope is that it's appropriate content. It has to do with the subjects that we're talking about. However, in some cases where you're talking with maybe a person who's suffering from schizophrenia or bipolar disorder, or even maybe other disorders such as obsessive compulsive disorder or anxiety disorder, you will begin to see other ones, such as in bipolar disorder or schizophrenia, you'll often maybe have a sense of grandiosity, a sense of they know it all, or that they're larger than life, or that they're somehow superior or have special kind of powers. Grandiosity is kind of one that comes around quite a bit. Let's see, suspicious. So for those who are either super anxious or have either, that are coming in for other reasons, maybe they are court ordered, or maybe a sense if you're dealing with working with a schizophrenic patient, they may suffer from paranoid schizophrenia or paranoia or a paranoid delusion. So they may be very suspicious in how they talk with you, and the content of their thoughts are suspicious. I mentioned before in the one above, their processes might be racing and tangential, so their thought content also might be very tangential. They may talk about delusions depending on the disorder, delusional disorder, schizophrenia, even portions of delirium, and neurocognitive disorders may show signs of delusion during your mental status or during the session that you will mark on your mental status exam. Again, the ones that you will want to mark most commonly then would be appropriate, linear, here we go, another appropriate, and maybe rational, right? So those are the ones that you would hope for as far as thought content. If you have a person with a delusion disorder, schizophrenia, bipolar with psychosis, delusions is something that you'll want to kind of keep track of if you're observing delusions. So are they bizarre delusions? Meaning, are they talking about aliens or something very odd, being in a video game, things that are just not even on the radar or normal type of situations that relate to life in general. Paranoid delusions, people watching them, especially kind of government conspiracies of people watching them or outside and out to get them. That's probably one of the more popular delusions. Erotomania has to do with kind of being in love or feeling that a person is either in love with them or they are overly in love with somebody else. So it can go both ways. They might feel that a movie star is in love with them and they are meant to be together, or they are just obsessed with and kind of a stalker-ish delusion that they are meant to be with that particular movie star or whoever it might be, neighbor, whatever. Religious delusions, that can come up as well. Believing that they have some sort of religious powers or special religious significance. Grandiose delusions, that they're going to write the great American novel, that they're the next Mozart, that they're going to have the next invention that's going to change the world. So that's really kind of grandiose. Somatic delusions, typically that they're complaining of some sort of somatic complaints. They feel like they've got a brain tumor. They feel like they've got liver cancer, and yet there's no substantiation at all that that's going on. Hopefully you would mark no delusions. Same thing with hallucinations. Hopefully you are able to say there's no hallucinations. However, during the session, look for the most common ones are auditory and visual. It's very rare that you will see things such as kinesthetic, where they're like tactile, they can feel something like bugs on them or other things. Let's see, what else? Olfactory, so smells, they're smelling something that doesn't exist. There's other hallucinations, gustatory, that's another one where they're tasting things that aren't there. But again, hopefully they're not showing any signs or usually I would say they're not showing signs of hallucinations. However, I have plenty of clientele that they've talked about auditory hallucinations. And that's typically described as kind of hearing voices or hearing sounds that they express that they're hearing them. However, nobody around them is hearing those. And the last one, at least for this section, is suicidal. So are they denying suicide? Is there some form of observation? Is there a plan? And is there intent? And we talked about that on Monday in the 6700 class. For those who were in that class, we spoke about suicidal ideation and what that means. And typically what you're going to find out, if they say that there is some sort of ideation, you're going to want to do an assessment as far as, do they have a plan? Do they have the intent? Do they have the means, the lethality to be able to carry it out? And then you'll want to do a suicide assessment. So that's this portion of the mental status exam. There are a couple of other small sections that we will get to here in a second. Okay, let's move through this portion fairly quickly. Homicidal, that's really been pretty rare throughout my career. However, if they're making some sort of homicidal thoughts or telling you they're having homicidal thoughts or making homicidal threats, you'll definitely want to document that and mark that as part of the mental status exam. Sensorium or consciousness, are they alert? Typically that's the one that I would mark for my mental status exam. However, there are folks that come in and they are kind of in maybe a sleepy state, or even sometimes disoriented a little bit. Again, all of these other ones are fairly uncommon. If they've arrived at your office, they're usually alert. So that one's probably the most common. However, again, it's good to be aware of what the options are in these areas. As far as orientation, this is what we spoke about in my 6700 class, as well as for those who attended in the Zoom hour. Orientation has to do with, typically it's orientation. They will say sometimes a statement, orientation times 3 or orientation times 4. So those phrases right there have to do with, does the person, are they aware of themselves, and do they know their place, situation, and time? So do they know where they're at, who they are, what time it is, or what day it is, those type of factors. If not, they might be oriented times 2, which is maybe place and situation, but time, they're unaware of time. So that's, if you ever come across orientation, that's what we're talking about. And if they ever say orientation times 3 or orientation times 4, that's what they're referring to. Attention, let's see. Usually attentive is what you're going for, or intact. However, as I mentioned, bipolar disorder, schizophrenia, even anxiety, what else? Attention deficit disorder. You will find that during the session, it may be their attention is diminished or poor, or they're distracted. Let's see. Or hypervigilant. I've had folks that either showing signs of paranoia or very, very anxious. They'll be very hypervigilant about what's going around the office, noises that are happening outside the office potentially. So those are things that you'll want to be paying attention to in that area. Concentration. Is it adequate concentration? Are they able to answer your questions and track your questions, or are you finding that their concentration is diminished typically because of attention issues or thought processing issues, to where they're distracted, they're tangential, difficulty concentrating? That will definitely cause issues in this area of concentration. So you may mark diminished or poor or fair. Memory, as I said, because we don't do really any testing with regard to in the realm of psychology, typically memory is just a matter, can they recall what happened yesterday, last week? That's typically how I judge memory. Are they able to tell me about the past week, or what happened yesterday, or even last month? What are some of the main events? If they're able to do that, great. Usually it's intact recent, meaning they could tell me what happened over the past week. Intact remote, can they tell me about what happened last year? Some significant events, not really super detailed, but significant events that happened over the remote past. Let's see. And intermediate, again, as I mentioned, kind of those things. Short term, maybe within the past year, and then, or several months, and then over the past several years, maybe. However, they may have troubles with impaired recent. I do have some clientele that are up there in age, or showing signs of early dementia, or because they are significantly depressed or anxious, they have difficulty. And maybe there is impairment in recent memory or remote memory. So those are things that you'll want to pay attention to. Again, you're not administering any sort of formal memory testing, such as, okay, remember the numbers 5, 7, and 3, and I'm going to ask you those later in the session. That's something that we don't commonly do as social workers. Not that that wouldn't be important, but that's just something I pick up on memory issues just based on the conversation. Here we go, impulse control. Is it adequate and good? Hopefully those are the normal responses. However, impulse control, as you've listened to their account of what's been going on over the past few days, or even in the session, are you finding that impulse control is limited or poor? Maybe they just told you that they went out over the past couple of days and bought a new car just on impulse, or they've spent money, or they gambled all their money away. Those are kind of some things that you'll want to factor in. Insight, this is a big one. Did they show good insight during the session? Were they able to track during the session of what you were talking about, what they were talking about, and showed really those connections that we want to see of the connections between their thoughts, emotions, behaviors, consequences, what they often call consequential thinking. Do they show that insight that if they don't eat in the morning, they're going to have they're going to be maybe lethargic in the afternoon because they're not eating enough, or sleeping issues? Or do they show good insight as far as the way they treated a particular person, that is going to have a consequence on the relationship? So for the most part, I would say insight for many people is good. However, they might be in a severe state of depression or anxiety where it's kind of fair insight. They're really kind of having trouble making connections between their thoughts and emotions and their behaviors. They don't quite understand why they're feeling the way they do, when in fact they've told you they've been in bed for a week straight, and yet they really showing kind of fair insight into that connection between I'm not doing anything in my life as far as getting up, brushing my teeth, putting myself together, and why I'm feeling the way I feel. So for me, that would be either fair to almost poor insight. Poor insight then ultimately would be they really have no clue of any connections going on between their behavior and the world around them, or the world around them and the impact on their behavior. They might even deny or have poor insight into why they're doing what they're doing. They might not even understand that their hallucinations are not, or they may think that their hallucinations are there, they are real, they are happening. A lot of people will know that the things are not there, but they'll tell you that they're happening. That would show that they have pretty good insight for sure. However, there are some folks that, whether it's delusions, hallucinations, paranoia, they might have very poor insight to where they really truly believe and will even tell you to your face that there's somebody out there listening to us. And when you talk about there's really not, and you even go and check, and still they deny that. So that would show some very poor insight. And then finally, attitude towards treatment. During the session, were they cooperative? Hopefully that is the one that you're marking, is that they were cooperative during the session. However, there are patients that are uncooperative depending on the population that you work with or the emotional state that they're in. I've had, again, folks that are dealing with schizophrenia or even bipolar patients that are in very irritable, agitated moods, and they don't want to talk, or they just kind of almost bulldoze you and buffalo you and kind of go right over what you're talking about, and that they're very uncooperative and suspicious and don't want to answer your questions or don't even want to listen to your questions. And I think that is it for this little section. We've got one more small section to go through. All right, this is the last one. The final ones that we're talking about is judgment. Do they show good judgment? Are they able to talk about the consequences of, that they are eating okay, that they're trying to get enough sleep, that their actions that they're taking are reasonable. They show that they're spending money the way they should be spending money. They're attempting to at least use good judgment in their daily functioning. However, there are folks that have more kind of fair or poor judgment. This particularly happens when you have people that are in a state of bipolar or schizophrenia or delusional or even high anxiety. They start making more fair or poor judgment calls. This might include to where they don't show up for work, or they're not calling into work for a particular reason. That for me is beginning to use fair or poor judgment. They're just beginning to isolate themselves. They're making either impulsive decisions if they're in kind of a hypomanic state. or manic state. They're going out and making purchases, spending money they don't have. For me, that's definitely kind of poor judgment. Again, fair judgment is where they're showing some insight, but they're really not making those judgment calls that they should on a daily basis to rise to that level of daily functioning that's important. Typically, again, this has to do with consequential type of thinking. Are they thinking ahead and making wise choices because it does have an impact on their life? Or are their judgments starting to slip a little bit and they're not making the wisest decisions that they should be, and it now is impacting their life, the people around them, careers, social interactions? Remember, when we're talking about areas of functioning, this judgment expands across not only their interpersonal or personal decisions of what they're doing in their own life, but how their judgment is with other people, situations, occupations, stuff like that. Patients' capacity to do ADLs. ADL stands for areas of daily living. So hopefully it's adequate. Hopefully they're able to get up, feed themselves, bathe themselves, grooming, being able to go shopping, being able to go to work, being able to keep their house clean, all of those daily living skills. However, I have plenty of patients that suffer from severe anxiety, severe depression, even schizophrenia, who have limited daily living functioning or daily living skills, where it's very limited. They've kind of stopped cleaning up their apartment. Their grooming is going down or decreasing. And so limited and impaired are a couple of areas of daily living or functioning that you may end up marking limited, impaired. There probably should be a fair down here as well, or poor responses as well, because certainly individuals' areas of daily living could go down significantly depending on the stage of their disorder or the severity of their disorder. Last but not least, risk of harm to self or others. This goes back to that suicide question as far as suicidal ideation. Are you finding, or in your judgment, is there plan, intent, and lethality? If not, that would be no risk. If there's passive kind of thoughts of those things, but if they're very non-specific, there's really no plan, no intent, but they're just kind of having the thought, typically that would land them in the mild range. However, if they are starting to have some sort of plan-ish, when the thoughts are becoming much more active, that would go in the moderate range. And then if the plans are becoming very specific, there's names involved, there's places involved, there's intent involved, there's means involved, certainly that area there, I'll mark that in red, certainly that would be severe, and they would need some form typically of to be in the hospital or observed. And sometimes even those in the moderate range, if their plan is becoming much more detailed and you feel that they can't be safe, or their thinking is now fair to poor, their judgment again is becoming fair or poor, typically that would move people that would be in the moderate state more towards the severe state, and they need to be observed or hospitalization. So these are judgment calls that you will make as a clinician. You're hoping that if anything, if they're talking about suicidal ideation, that it's more passive, there's really no plan or intent, or if there is some sort of plan, it's super vague, and they've told you they would never do it, or it's just a thought, that would be in the mild range. But if that thought is gaining more traction, they're ruminating, they're starting to think about it more and more, and even then, if there's no intent to do it, but the plan is kind of maybe formulating, that would be likely more in the moderate range. But they tell you, you know what, I'm going to keep myself safe. I'm not going to be doing anything. But yeah, I've kind of had these thoughts about how I might do it. Again, that would be moderate, but that would be one where they say that, no, I can be safe and you can trust in their safety. And typically a crisis response plan or a safety plan would be appropriate. So that's the importance of that risk of self to others, is to make a clinical call with regards to risk. There's a mental status exam. Again, it's quite extensive, but this is so important after your sessions because it does help substantiate your diagnoses, and it should be matching up with the symptomology that you're observing in front of you with the diagnosis that you're going to put in their chart. A mental status exam can be done. You can be marking those observations every session. Some agencies, you just need to make sure that you're doing a mental status exam every so often, maybe every couple of sessions or few sessions, or at least document what their mental status is. All right, there you go, mental status exam.